Got you got anything to present? No.
I'm coming from 8PP, so I brought in a recipe this brochure.
Yep.
So that I got a case of a 5 month 26 days old baby boy who presented to us with a history of this is the second admission. The first admission is previously postnatally for prolonged jaundice. So presented with us for cough and runny nose for the past 2 weeks, which was worsening for the past 3 days, chesty in nature, and also there's one episode of post-acid vomiting today morning, which is a clear discharge lah. Otherwise got rapid bleeding for past 2 days, which is gradually worsening, and the mom noted chest indrawing. Otherwise there's no fever. Patient is still active, still can tolerate orally, feeding, 3 scoop 100 ml 2 hourly, no loose stools, no sick contact, and not doing any nasal clearance at home or not given any syrup PCM at home lah. Yesterday, the night before, went to GP. They give Nepsaline times 1 and then referred to us to come to hospital. Otherwise, asthma profile wise, this is the first nap in life. No atopy or eczema. Mother said mom has eczema, but otherwise no parental history of asthma, no aero allergen sensitization, and no family history of thalassemia or blood disorders. Birth history wise, born via SVD term, 37 weeks 2 days, birth weight is normal 3.1, and the history of admission and birth for jaundice lah, requiring phototherapy. Immunization is up to date. Diet history, tolerate bottle feeding, 3 scoops 100 ml 2 hourly, and developmental wise is up to age. Gross can sit with support, can roll from prone to supine, fine has the palmar grabs, can drop the toy when another toy is given. Speech can babble, turn to sound and has laugh. Language mouthing shows response to play lah. Family history, father is 38 years old, radiographer at PPUM, mother is 37 years old, works at admin executive. This is the 4th child. Got 3 elder siblings, 8 years old, 6 and 4. All have no known medical illness. The eldest sibling got mild eczema, but otherwise no history of asthma in the family. Child is sent to nursery 8 to 6 p.m. Mother is not sure of the total children, but and also not so sure about the sick contact. Otherwise, nothing is informed to the parents lah. Upon presenting to the ED, on examination, child was tachypneic, RR is 50, and there's mild SCR noted. Lungs were bilateral crabs with equal air entry lah. Throat was not injected, and tonsil not enlarged. So started on nasal prong 2 liter and nap saline 3% and suction. And then reassessment, RR was still 50, but the recession much improved, and lungs were still bilateral crabs. Chest X-ray was perihilar haziness. Then admitted to ward. So upon admission, the examination, the RR was child was active, good pulse volume, warm peripheries. RR was 36. There is mild SCR, but there's no stator, and there were dry skin noted over the trunk. Lungs were equal air entry, bilateral crabs, no bronchi, and the blood investigation wise, urea creat was normal, CRP is 4, HP is 12.2, predominantly lymphocytes, platelet 520.
How old again is patient?
5 months.
5 months old.
Yeah.
So how many times already got nap before?
This is the first nap.
First nap,
the first
never had nap.
admission for this type of symptoms.
Okay.
Yeah. So over the next the progress and ward, the next day we are able to bring down to room air. Then we monitor for another 24 hours. Eventually, the child upon day 2 of admission, child was not tachypneic anymore lah. The SCR also much improved. There were minimal crabs over the bilateral lungs. So hence the child was discharged with no medication was given lah. More like we just asked to use the nasal steering for gentle suctioning.
Okay. So come with fever? No fever.
No fever.
Just cough.
Rapid breathing and cough.
Free breathing and cough. Sick contact.
The mom was not sure, no sick contact at home, but unsure at the babysitter.
Babysitter. How many children in babysitter?
Yeah, that's why she was not sure, but she said about 10 plus.
Many people
Yeah,
lah.
but she's not sure
Okay.
on the exact number.
So vaccination until?
Vaccination is up to date. The last given was the 5 month one complete already at KK.
Any extra immunization? No. Okay.
No influenza vaccine.
Alright. So why is it important to know history of the neck even though the patient are only 5 months old?
History of what?
Why we want to know history of nebulization?
or to see whether is it recurrent or is this
Okay.
the first episode.
So if this is the first time, okay lah, you can label that as a bronchiolitis. If they already many naps already, say semua 2 bulan, 2-3 kali, 3 months, 3-4 kali. So what kind of diagnosis you can think of?
We can ask more history of when these particular events are occurring, if there's any particular trigger or maybe we can look into multi-trigger wheeze.
Okay, other than multi-trigger guys, pneumonia
There's
don't cause
fever,
recurrent wheeze. What else?
Viral-induced wheeze.
Viral-induced wheeze, okay.
Especially this younger
Alright.
age.
So viral-induced wheeze and episodic viral wheeze is the same thing or not?
Viral-induced wheeze is mostly caused by the do you mean the viral disease once, and episodic wheeze is recurrently happening.
Okay, so it happened many times lah. First time you can put viral-induced wheeze lah.
Then eventually it's episodic.
Okay. So patient the preschool wheeze ah. Alright. So how many times you can diagnose bronchiolitis? Patient come with rapid breathing.
2 times.
Why? Why you said 2 times?
Because the more it happens, it's more like
Okay.
multi-trigger.
Think about the pathogen. So the most common pathogen
For
bronchiolitis?
bronchiolitis is the RSV.
Okay. RSV, sama? Ada any other viruses can
The
cause?
most common is RSV, but
Most
other
common
than
lah.
that, like metapneumovirus or
Yes.
influenza also can cause.
Yeah, can. All can. Alright, but most common is RSV. So, what happened pathophysiologically?
It affects the smaller airways, the bronchioles, so it causes more mucus secretion and edema.
Okay.
So it causes it can cause the bronchoconstriction.
So, when there is edema, there is hypersecretion of mucus. Can cause what?
Bronchospasm.
No, it doesn't cause bronchospasm.
Bronchoconstriction.
What does the edema? What does the mucus do to the small airways? Yeah, it blocks the small airways lah, and then these children they have very very small lung. So imagine the airway must be even smaller. Okay, so when you have mucus, partial obstruction or total obstruction lah. If total obstruction, what happen to the alveoli down there?
It will shrink up.
Not shrink lah, atelectasis lah. Don't say shrink. Use the medical term.
Okay.
So atelectatic lah. Okay. So that's why cause the respiratory distress because of the atelectasis because of obstruction, total obstruction lah. Okay, so that's why you see this recession and all that. Why small children have recession? Why big children don't have recession? Why easily seen in small children compared to big children?
The recession.
Yes.
The use of the accessory muscle.
Yeah, even big children also can use accessory muscle lah. If you use accessory muscle, you probably see recession as prosternal or whatever. But what you can see the subcostal intercostal recession much easier in smaller children, in infant.
Is it because of the increase in the intrathoracic?
It's not really something to do with pressure cavity. It's something to do with thoracic what? Compliance. The chest wall compliance. Understand? How rigid the chest wall is.
Okay.
Understand?
Okay, yeah.
Smaller children, they are
Small,
softer,
non-rigid, okay.
non-rigid. They're more compliance, mean they follow the lung. Alright? So when you have obstruction like this, how do they compensate? Is by either breathing faster or increase intrathoracic pressure by doing all this recession lah. So we want to overcome the very high pressure due to the obstruction lah. So because of the pathophysial airway edema, hyper secretion of mucus, so in the end ultimately RSV, how do we treat?
More to like supporting measures, they give oxygen and then
Okay.
gentle suctioning, clear the airway.
Yeah.
of the child.
Okay.
And
Before suction, where you can
naps.
definite lah. So saline or saline 3%, which one is better? Do you know?
3%. I know that's the one giving in the ward.
Yeah, some say it might be better, but I don't know lah. In terms of duration of stay, I think it's about the same. But it is practice here lah with the saline 3%. Okay, so only give saline 3% for this bronchiolitis, plus so-called pneumonia with a lot of secretion ke apa ke lah. Sometimes they are like cross each other, something like that. But don't give the saline 3% in big children pneumonia and all that lah. Okay. But if chronic suppurative lung, yeah, you do give the 3, 5, 6%, whatever. Okay. So if patient RSV, you said the treatment is supportive. Okay, if you see the child is breathing, the effort is not very good. Okay, so or you patient already on isopron, you already done suction, secretion got a lot, but breathing effort still very, very labored. So what you want to do?
Escalate the oxygen.
Okay.
We can start the optiflow or CPAP depending on the if there's signs of worsening respiratory distress.
Why CPAP? Why optiflow? What does it provide compared to normal oxygen?
It causes the continuous pressure, so it helps the child to.
So there is pressure. That's the main thing lah.
Breathing,
so the pressure. So what does pressure helps? How does the pressure helps?
So what I understand is CPAP is one positive airway pressure. So it like sometimes we even like for some children we give in the room air setting, so it helps to help the outside air to get into the child.
What does it do to the airway?
Like
what? From this one, epileptic, open up the airway.
I'm not sure of the medical term. If we make open up the airway and put positive pressure, like that gives in the.
What are the two pressures in the airway?
Is it the setting?
Yeah, the two pressure.
The PEP.
PEP is what?
I only know because I like to play.
PEEP is what? P stand for what? E stand for what? E stand for what? P stand for what? Just make a wild guess or educated guess. The end of the P is pressure. The two E is what?
And expiratory.
Yes, and expiratory. The first one, the first P? Positive and expiratory pressure. Okay, understand? Alright. So what does PEP do?
So it means it open up the and expiratory.
Keep the airway open pattern during expiration. Okay, because the problem is what we talked about just now.
Because of the constriction.
Because of the collapse. Atelectasis. Atelectic because of this mucus plug and all that lah. Understand, right? So the PEP keep your airway open even during an expiration because lung is diseased, it collapse. So when you have PEP, it keeps your airway pattern during an expiration, doesn't collapse. So your next breathing effort will be much easier. Okay. So patient don't have to use our energy to basically keep the airway open lah by producing their own PEP. How do patient produce their own PEP?
By using the more accessory muscles and all.
Baby does do this a lot. Not just they do what sound?
Oh, grunting.
Yeah, they do grunting.
Because they exhale through the partially closed.
Yes, they're just trying to create their own PEP. So you know already lah. So that's the concept they bring over to doing the ventilation lah. Okay, then there's another pressure lah, which is PIP lah. PIP tu kalau you set BiPAP, one is PAP, one is PIP. PIP is positive inspiratory pressure. Okay, alright. So if you say patient already on PEP, already on BiPAP, CPAP, whatever, patient still throw. So intubate. So how do you want to intubate? At least know some basic intubation punya knowledge. Okay, what pre-med you want to give? Midazolam can, some more. Can, some more. Can also. You either choose one lah, ketamine or morphine. Okay, it depends on the availability. Mida is for sedation lah. Morphine and ketamine for what? Sedation plus pain. Okay, another one. Sometimes we also use the third medication. What? Sometimes patients still keep moving, not sedated. Not enough, still moving.
Usually it's for
to paralyze. What is it called? Huh?
Not chlorohydrate.
Not chlorohydrate lah.
Okay.
Paralytic agent lah. We give also. What paralytic agent do you know? Never seen intubation lah. down there.
APB usually if CPAP and all and like worsening then we.
Have you seen any intubation before?
Not in peace.
Not in peace lah. Ada they use what?
Sorry?
Ada. Same lah. Ada also use the same drug. Yeah, the mida, morphine, ketamine, whatever. Plus another drugs for paralysis. Paralytic agent. Tak pernah dengar rocuronium, succinylcholine, whatever lah. To paralysis lah sometimes. Okay lah. But if neonate intubation, sometimes we tak bagi apa-apa pun to newborn and all that lah, because they are quite soft, so and they don't really struggle very much. But dah, they 1 week of life, 2 weeks of life, they struggle, they scream, their lung up, then probably so we also still give all those 3 medication lah. Give lah morphine and all that. Okay, but newborn intubation, if you go, I know you all don't go standby nowadays. If you go standby, the MO just intubate, just like that lah, without giving anything. Because most of the time they just flat, baby flat already, just intubate lah. No need to give medication. And some more tak ada line lagi nak bagi. Okay, alright. Okay lah, that's basically Respi is quite easy lah. So I ask you sampai intubation to. Okay lah, I just ask you one more unique question lah. One thing, since just now you said patient have prolonged jaundice. Okay. Alright. It's okay, everybody goes the same thing. I ask one piece question, one unique question. I'll let you all prepare whatever case you want. You can answer your prepared question. I give you something you probably can answer lah, but it's okay. Just I need you to know at least something. So prolonged jaundice, the most common cause apa? Okay, it doesn't matter lah. Just list me the causes of prolonged jaundice in neonate. But speedy deficiency can cause prolonged jaundice. No, it doesn't cause prolonged jaundice. Lasts too long already. Okay. Breast milk jaundice is another one. That's basically the most common one lah. Infection can. Sometimes patient had recurrent infection or they can have prolonged jaundice also. Okay, sama?
Any congenital.
Congenital what?
The liver diseases.
Can. Some idiopathic neonatal hepatitis can cause prolonged jaundice. Sama? Thyroid thingy ada? Congenital hypothyroidism also can cause prolonged jaundice lah. The most important one apa? You ask about stool colour. That's basically the reason we do prolonged jaundice screening.
Oh,
the stool colour is pale. What obstruction? Dekat mana?
The bile.
Bile obstruction. So, what is it called? Biliary what?
Biliary cholestasis.
No. Biliary what? What's the name of the condition? Biliary something. Biliary atrophy. Kalau small or partially obstructed, we call what? Stenosis. Fully obstruction, we call what? What's the medical term? Partially obstruction, we call it stenosis. In the vessel kan, whatever lah. It's fully obstructed. Stenosis is partial obstructed. Like your tracheal atresia apa semua tu. Atresia lah. So biliary atresia, tak pernah dengar biliary atresia.
The thing is I never cover 7 PA, so this is like my med school knowledge.
Doesn't matter lah, but it's still jaundice. You still have to know lah, even though you don't see. Okay, so prolonged jaundice, basically we do prolonged jaundice workup at day 14 of life to rule out. The main thing is biliary atresia. Okay, because what's problem with biliary atresia? Kalau you don't correct it before certain age, it causes liver failure. So that's why we want to diagnose them early. We go for surgery early, because the surgery success depends on how early you do the correction. Okay, the later you do the correction, the liver become more cirrhotic. Understand? Alright, so you do less than 2 months, the prognosis is much better compare you do surgery post 2 months. It doesn't mean they don't do lah post 2 months, they still try to do, but the success will be much lower. Okay, so that's why we do prolonged jaundice lah, because we want to roll up the atresia, then we also want to roll up congenital or subclinical hypothyroid lah. Okay, so congenital hypothyroid, another common thing also lah. So ultimately, kalau all roll up negative, patient term baby, berweight okay, gaining weight, fully breastfed. So the diagnosis will be what? All the investigations semua normal already. Fully breastfed, weight gaining. Just now lah, apa lagi? Breastmate jaundice lah. So breastmate jaundice is diagnosis of exclusion. So you roll out other thing first. But some of the children, they don't fully breastfeed, so it's a bit difficult to say it's breastmate jaundice. Some because the mother may top up 2-3 times, 4 times a day, so it's not really exclusive. But if like 70-80% is breastmate, it's still okay lah to put diagnosis as breastmate jaundice. Alright, but breastmate jaundice, do you ask parent to stop the breastmate? Alright, so you just counsel what to counsel. Most of the breastmate jaundice will go away by 1 month. Some may go up to 2 months. I've seen sometime up to almost 3 months lah. But they don't have to stop the breastmate lah, because it's good for babies, but there is some enzyme in the breastmate, glucuronidase enzyme. They kind of like break down the bile. It's the gut also absorb back the bilirubin go back into the blood vessels. That's why the jaundice is very difficult. It's very slow to go down lah. Okay, alright, okay lah. So next the book.